Hi, everyone. Welcome to the operations session of Beyond the Treatment Table. I'm Stephanie, your host for today's panel on remote therapeutic monitoring. Our guests are Craig, Nisha, and Haley. And I'm going to give them each a quick minute to introduce themselves, and then we'll get right into it. Craig, do you want to go first?
Sure. I'm Craig Pfeiffer. I own a practice with locations in Kentucky, Indiana, and Illinois. And we have had our ups and downs and ins and outs with remote therapeutic monitoring, tried a lot of stuff that didn't work and a few things that did work out pretty well. So I'm excited to join the panel today.
Thanks, Nisha.
Hi, I'm Nisha Wetzel. I am a minority partner of a private practice in North Carolina. We're just outside of Fort Bragg Army Base. And we too had some trials and tribulations when we first rolled out RTM and tried kind of a unique approach and ended up kind of with it working for us. So excited to just kind of share a little unique story.
And Haley.
Great. Hi, I'm Haley Siegenthaler, and I am a partner with Kitsap Physical Therapy in the Northwest, and we have 8 clinics. We did RTM a year ago with a company that went out of business, and then we did it again this year, and we've had a lot more success. I'm the Chief Operating Officer, just started this January for our company, and so that was my first big project, and that's why I'm here today to kind of talk about what we did differently the second time around and kind of how things went the first time versus the second time and where we are now.
Thank you. I'm excited to hear what you did differently the second time. So, quick reminder before we get right into it. Oh, hi, Dave. This is meant to be an interactive session, not a webinar. So, if you can turn your cameras on, if you're not driving, if you're eating lunch, that's fine. Turn your cameras on. And if you have questions, you can just raise your hand or use the raise hand feature just in case I don't see you. Otherwise, drop things in the chat as they come up, and then I'll call you to come off mute, and we'll make this a little bit more of a discussion than, listening passively. Let's start off with where everyone currently is with RTM. So, are you currently using it? Are you curious about it? Are you looking to improve what you're doing? And you can just drop that in the chat. Or I might even call some of you up. So Jill, I know you're interested. Do you want to pop off mute and share a little bit about where you're at in that process?
Sure, sure. I have 2 clinics in Staten Island. Thanks, Stephanie, by the way. Um, and I was just looking into RTM as this Zoom came about. And I think the questions for me are that it seems like a heavy lift for a smaller clinic with not as much reward to in payment. So I'm struggling with, do I hire the PTA? Do I make it a separate um almost like a separate department? Just my thoughts recently on it.
Yeah, and that's exactly what we're going to cover, like the different ways of implementing. Ben, I don't know if you stepped away. I saw you're testing it. Did he walk away? Lindsay, you're also in the testing phase. Anything you want to make sure we cover? Any questions just starting out?
Yeah, so we have a small clinic, 2 PTs, 2 PTAs, and really I just have one therapist who kind of took it by the horns and is doing it pretty much all on her own. And I guess figuring out how to integrate the other therapists and how to not have all of the workload just on her, or even just, yeah, keeping track and organizing and just the logistics of kind of what's worked for people because we're new to it. It's a new concept that we're just kind of a few months in, and we've got maybe 10 people on caseload that are doing it right now. And it's going okay-ish, but I'm assuming there's way easier ways to keep track of some of the stuff we've been doing.
Definitely. Okay, it sounds like everyone else is still in the exploratory phase from the chat. Anyone else have it up and running other than Dawn is with me? So I know we've had it for about 2 years at House PT now, and we kind of have a hybrid model where each therapist manages their own caseload, but then one person oversees and does the documentation to take some of the workload off. And we haven't fully got that figured out yet. Craig, how are you doing it?
Our model is that every therapist does it with their own patients. So we have a very consistent therapist patient model. And we were, told looking at it initially of just like, yeah, the experts are just like, yeah, that doesn't work. We've never seen each individual therapist learns and understands RTM and the coding and those kind of things. And that's probably why it took us like, 2 to 3 years to get it actually figured out. But yeah, we have every therapist does RTM with their own patients, documents it, and does it like that.
So they do start to finish.
Yeah,
Okay.
and with some very high degrees of success and some much lower.
Yeah, we'll definitely dig into that because I have questions about how symmetrical it is. Nisha, what's your model?
So ours is fully centralized. So we have one person that is solely responsible. That is her full-time position. That she manages the RTM for all of the patients, pre-charts the notes for the clinicians, handles the billing, etc.
What does that time look like? How much time is she
She's currently
spending?
30 hours a week.
Okay, and that's her primary role.
Correct. And we have 19 providers.
Okay. Haley, I know yours is a little different.
Yeah, do you want me to start with what happened in 2025 really quick so everyone
I
can
would
kind of hear
love
that
the
story? Okay.
contrast. Yeah.
So in 2025, we decided to get our TM rolling. We have 8 offices. We're like a big-ish growing company, and we decided to go with a white glove approach. Our executive committee, we met with several companies, and we decided to go with one that had very little financial upfront cost to us. And it was a company called Copper Health. And we went through all of the growing pains of getting our clinicians off of MedBridge and into the Copper Health portal and learning how to do the HEPs and getting our TM going. We had very little success. There were just a lot of challenges. And by July, that company went out of business. And they shut the entire platform down about a month and a half later, leaving us to switch every single clinician back onto MedBridge. And that was just really hard on our team. Like clinicians are already facing burnout with documentation requirements and just the speed at which we have to deliver care these days. So having them all switch into a new system and then back to the old system felt really bad on the admin part of our company. We felt really bad for all of our therapists. So we gave everyone a break. We're like, okay, just get back to MedBridge. We'll just kind of coast through the end of the year, do what we're used to. And then we decided to try again because we really do believe in RTM. We know that it's best for our patients. We want to be a part of these new codes. And so we switched to Prompt acquired PT Wired and became Prompt Engage. So we switched everybody over mid-November, early December of last year to start using the platform. The second time around, we gave our clinicians a lot more headway, a lot more lead time, a lot more training. We didn't turn anything off right away. We let them kind of use both and start switching their templates over. We didn't start RTM right away. We just switched the HEP platform first for a few months. In January is when we just decided not to renew everyone's HEP access to MedBridge. So then they were all using Prompt Engage. And February 1st is when we turned RTM on this year. And so we started doing RTM. And the approach that we have chosen both times for our company is the white glove approach. So we contract with another company and they have remote care navigators who essentially do what Nisha's 30-hour week clinician is doing. And we have a remote care navigator that manages 2 offices at a time. So we have 4 of them across our company, but they work for another company and they manage all of our RTM patients and portals, and they're in communication with our therapists. So what that looks like for us is a smaller margin, but what it looks like for our clinicians is a lot less work. And maybe at some point we'll switch over and keep educating our therapists on the codes and everything. But right now we feel like our staff are just so busy keeping up with everything else that we wanted to have an approach that felt like the least shift for them. So that's where we are right now. We're just a few months in.
Any questions on the different styles so far? Gerald, do you have anything? Not yet.
I have a comment if that's all right.
Yeah, of
I
course.
Hi,
So
Dave.
I work with Haley and she's phenomenal.
Honorary,
That's why I asked
honorary
her to,
panelist.
yes, yes, our panelist. And that's why I wanted her to do this because she knows the product well and is a much better presenter. So, um, but part of the reason we chose to go with the white glove approach too is our feeling is something, a percent of something is better than trying to take all, in our case, all of something if it means losing staff potentially and just building frustration. And we just wanted to make it as easy on our team as possible. And if that meant we would gain some revenue in the process, but not certainly a smaller margin, we could be happy with that, at least at a starting place. So that was our philosophy going into it anyway.
Before we continue to get into the business side of things and talk about the pros and cons, why would we want to use this service clinically? What have you seen? And we'll go in order, Craig.
I just saw that question pop up and I thought it was a really good one of like why even get into it. Because when these codes first came out, I remember like reading some stuff about them and just thinking like, it seems like it's not going to pay great, and it's kind of a big shift for clinicians to need to learn it. And I was not on board with RTM myself. And then I actually got asked by somebody, because I do some teaching on therapeutic alliance and patient engagement and relationships, that they're just like, oh, we want to have you come present on like utilizing digital care and like RTM and like how that enhances patient relationships. And it's one of those things where I was just like, listen, I'm not an expert, but it kind of sounds like some things might be trending in that direction, and I probably should learn it. So in preparing for this presentation, I started to look at a lot of the research and a lot of the things regarding patient relationships and communication and what people are starting to expect from medical providers and all that. And it's like the expectation for digital communication and being able to contact your provider between sessions is going way up. The fact that like it used to be like, oh, it'd be really nice, and people, 20 years ago, if I can call and leave a message, and then my provider will call me back at lunch or at the end of the day or whatever, that's great. Well, now like nobody wants to call us and leave a message, right? They want to have digital communication to a point where for us, and we've kind of cleared the HIPAA part of this, but like so many of our therapists text with their patients regularly. So as I was kind of looking into the relationship part of it, not only is it something that patients want the connection, they want the access to us, they want to be able to make changes on the fly, just being able to say, like, hey, I did this exercise, it hurt at home. How can I adjust it? That's a really nice thing for people. And kind of found out like, no, our therapists are actually already doing this and we're not getting paid for it. So that was where it came for me of like patients want it, our therapists are already doing it. All we need to figure out is like, how do we get paid for it? And that's what brought me over the edge with it of just like, okay, this has now become something that we definitely need to figure out.
Clinically, RTM is shown to keep patients more engaged. So patients are more likely to complete the plan of care and attend all their sessions when they're engaged in RTM. They also are showing just in the early data, we haven't had RTM for a really long time, but it's showing that patients' functional outcome scores are higher when they're engaged in RTM. So our patients are getting better, they're sticking with the plan of care, they're getting higher functional outcome scores. And then on the financials, those are the clinical reasons. And they love having that connection to us in between sessions, especially our specialists, maybe our pelvic floor PTs that are only getting these patients in once a week. They can now check in with patients in between those sessions. and have that digital access point. But then financially too, our margins are so small. And this is just one small way to help bring that margin back up a little bit. It's a double win.
Ours was sort of a little bit unique, and like Craig, when the codes first came out, we were actually sort of cautioned not to use them, that they were, going to be suspect to a lot of audits and things like that. And I too was a little suspect on, again, whether it was going to create more labor for the clinicians and whether the lemon was worth the squeeze, given, the chance for audits and things like that. And so we started it actually sort of as a charity case for an employee that was leaving. So again, we're outside of a military base, and so we have a somewhat transient staff as clinicians come and go. But a fair amount of our clinicians end up coming back. Fort Bragg is sort of a hub of a lot of military units, and so folks may go, but they usually end up coming back. So we had a gal that was going to be moving to California and really didn't, it was supposed to be a temporary change of duty, and she was going to come back and didn't want to deal with licensing in California. They're not part of Compact, and trying to find a job for a short period of time that she knew she wasn't going to be there, very long. And so we were kind of looking at ways in which we could keep her. And we were kind of looking at maybe some remote administrative work for her, something like that. And she's a licensed PT. I should probably throw that in there as well. And so we said, well, why don't you look into RTM and just see if that's something that we could truly do remotely and you could man and kind of house. And like Haley, we demoed a lot of companies to see what would be sort of the most user friendly, not just for her, but also for our patients. We have a pretty high Medicare payer mix, and so wanted to make sure our older folks would just have a little bit easier time utilizing the platform. So we really went out with the intention of, if it kind of broke even and kept her employed and engaged for a year with the organization, we really were not, if it made a few bucks, great, but we actually were not really interested in it being but we weren't expecting it to be a, financial windfall for us or anything. And then surprisingly, it just ended up being profitable. And so we kind of started it as a trial basis, and it ended up not just engaging her and keeping her, with the organization. She's coming back to clinical practice soon. But it also just ended up financially sort of working out in our favor as well.
I sit right in between you and Craig, where we have one of our therapists who works remote, is part-time overseeing just the documentation part of things and just enrollment. And then we have the clinicians doing their own enrollment. And we started doing it not for the potential monetary benefit, but because all of our clinicians were already giving out their cell phone and checking in and updating HEPs by text. And I wanted to move that over to something a little bit more contained. Now, I don't take Medicare in my practice, and we're also out of network. I know that there are a couple cash-based clinicians on the call, and also Jill, I believe you're fully out of network, no Medicare. Any questions on that part of things before we keep going? How it would apply in your setting? I'm gonna throw it to Ashley first. And then Lindsay, I saw you came off mute. I'll come back to you.
Okay.
I mean, we do it anyway, so I feel like it's part of our kind of our model of care is that we're checking in. It's just kind of as a package deal. You're scheduling a cash appointment with us, and all the bells and whistles come with that, and that just includes checking in with patients, talking to them in between appointments, sending them home programs, being in kind of constant contact. So, we kind of just call it concierge care because that's what you get. That's what you're paying for.
Lindsay, what were you going to say?
We are primarily Medicare. So coverage hasn't really been an issue, but we have some commercial insurances, and we've been finding that a lot of them do not cover the RTM codes. And then we're kind of in this weird place of, then do we charge our patients the full price for all of the RTM codes when we weren't we said we don't know how much your insurance will cover. You might owe some. We don't really know the extent of most of the commercial insurances because it's a newer concept. But some of them we've been finding that would owe all of it, like some of the Blue Cross of Illinois plans. And so we need to figure out kind of a process of how to, I don't know if we need to have like a contract up front that if your insurance doesn't cover it, you would be responsible if we do enroll you in the RTM process, or I don't know if you guys have found ways that are that work well for when insurance doesn't cover it, I guess.
I can take that one. We wrote off a ton in the beginning. And we just sort of just agreed to kind of eat those costs because we
Yeah,
didn't know. And
that's
I
kind of what we're
didn't
doing.
feel comfortable charging a patient if,
Right.
we didn't have the information. I didn't feel like the patient was fully informed on their financial responsibilities. So in the beginning, we had to just sort of test it out for just, we had some good information. Obviously, Medicare was going to pay and Humana was going to pay. We had some information, but then Humana does some squirrely things with charging additional copays for patients, and that felt gross. And then
Right.
just some of our commercials. Our Blue Cross of North Carolina does cover it, but our out of state Blue Crosses do not. And so we had a lot of just trial and error. And so until we kind of identified who would and who wouldn't pay, and then just we weren't auto enrolling anybody that wasn't paying. But until we kind of figured that out, we ended up writing off quite a bit. And then now we've just built that into the consent. We let them know 2 or 3 different times that there may be a copay or coinsurance associated with this. If you have questions, let us know. You can opt out anytime. We give them a lot of out opportunities with it, but they're fully informed upfront that they may in fact have a copay now when we know, who's covering what.
Okay. That's helpful. Thanks.
Okay. Let's just go through pros and cons of your model. So, Craig, you have all of the clinicians managing everything start to finish.
I think the biggest con is a relatively obvious one. Where like these, it's an odd code set where it's like some of it is like, oh, this is a 30-day thing, and then this is a calendar month piece. And so for clinicians like getting the hang of what like it's hard to get people to bill like therapeutic activity as opposed to therapeutic exercise at times. And just changing coding habits can be tough. And this is a more challenging code set to understand. So that's been the biggest hurdle, getting 40 people to know, to feel comfortable with when stuff should be billed and how. And we made an EMR switch at one point that just made it a little bit easier for people to know when it's appropriate, when it's not appropriate, know that it'll block you when you can't bill that code. So that was a very helpful thing. But the con is that it's way harder for 40 people to learn something new than it is for 1 or 2 people to learn something new. The pro is that it's kind of like it just becomes our normal relationships, right? Of like, as much as I would want to, like I can hang out with my parents and have them over for dinner and everything, that like I don't really always want to text my parents, but I don't get to outsource that part of our relationship, right? So for us, where like we're very big on connection and relationships, is kind of the thing that we're trying to um, do better as well as we possibly can. We want to be the best therapy company in the country at connection and patient relationships, right? Well, the digital stuff, we decided like it wouldn't be us to outsource that to somebody who doesn't have that in-person relationship established. So that's the cool part is patients have loved it and responded really well to it because they are literally like messaging with their therapist, with the person they know. And so that part has been the biggest pro for us is it enhances the patient relationship.
How do you deal with certain therapists who are maybe not as open to it?
I mean, we had 2 years of most of our therapists being not terribly open to it. So initially, we kind of presented it as like, hey, here's this thing. It's great. Like, we're just going to give you the case for using it, and you probably already are based on like texting with your patients and those kind of things. But what we did is we never gave anybody like a big enough like reason to change habits, right? Because it is a habit shift, even though like anybody who's done it's been like, oh, it's not that bad actually. Like there's a couple uncomfortable weeks, and then you kind of get through it and you realize like, oh shoot, like I can throw this into my workflows. It's really not that big of a change. Uh, but getting people over that, we did not get that right for a very long time. Uh, There was maybe one of our biggest success stories is I got to hire somebody who's a former patient of mine, somebody who I cared very deeply about and wanted to see her succeed and wanted to work with us, and got a DPT degree. And we did not have a patient caseload for her. It was one where I was just like, listen, um, I want to hire you. I'm going to bring you on. We don't have a place that patients are coming from to see you. So when we can get you a patient, it is like you, it's everything. Like it is, you got to keep that people, keep them engaged. And she was the only person that I said, like, you're going to do RTM from the very first visit. Like everybody else, it's optional right now. For you, it is not. Um, and she went from somebody who had like the odds were against her, as she had the lowest rate of patient drop off of ever. We hired 13 new therapists that year. She had the lowest rate of patient drop off of any of them. And she also, we measure how many patients call in and say, like, I want to see each individual therapist. Like, I don't want to get PT. I want to see my therapist. My therapist is. And out of that, class of 13 people we hired, she still to this day gets the most people who call and request her. So it went from this, like we saw this like little case study of it, of just like, no, no, no. When we tell somebody it's not optional, you're going to do this. Um, Basically what we ended up having to do is this year is tell people like it's not optional. You're going to learn this. It is too good of a thing for your patients. And it is the thing that allows us to bring up the salary range. So that's what your patients are getting. That's what you're getting. And it's not optional anymore. You are going to learn this. And that was what got us over the hurdle.
I had a very similar experience where I introduced it to our team of four therapists all at the same time. And there was, lots and lots of ups and downs of who was using it and how often. And then my newest therapist came in, and after about 2 or 3 months, she said, compared to my last clinic, my inbox is always empty because everyone knows what to send me through RTM, and this has changed my evenings. So that was really cool because I thought there was going to be the same learning curve, but for her, she didn't know any different. This is just how we do things here.
One of the
Nisha.
things our therapists have really enjoyed is like there are no boundaries for text messages, right? If somebody sends you a text, they kind of expect a response back pretty quickly because that's what we're used to with text messaging, right? Well, when you
Mhm.
use an RTM platform for that same message, like the expectations are completely different. Like that shut off at 5 p.m., right? That I will get back to you. If you send me something at 9, I'm not going to see it until I'm in the next day. And I will get back with you tomorrow. And everybody is really good with that. But when we are clinicians receiving text messages from patients, we feel a pressure internally. And they also have an expectation of you're going to get back with me quickly because it's text messages. And that's how text messaging works, right? This platform has helped our therapists be like, no, I can actually shut that off. I don't need to respond when I'm not working.
That's huge. Nisha, pros and cons of having a centralized system.
Yeah, I think kind of similarly working on just relationship building. We're a pretty low volume clinic and majority of our patients are return patients. And so that piece of it was really important. And so I think one of the biggest pros is that this was a clinician that already worked with us. And so she knew all of the PTs, she knew, how we all kind of operate. She knows our culture, she knows kind of who we are. And so I think being able to, just it felt very authentic in speaking with patients, or there was a similar, conversation, whether that's happening in-house when the patient would come back or when they're communicating with her outside. So I think that just the familiarity of her with our organization was a huge pro for us. Obviously, there's no increase in the workload for the staff because she is enrolling everybody. She's doing all of the communication. She's pre-charting in the documentation if there's anything pertinent that the clinicians then need to follow up with in face-to-face, or need to adjust anything in their care plan. She's pre-charting that. When it's ready to bill, she's pre-charting, and for the we're on prompt, so she's putting in the treat and flow tab and when it's ready to go for billing. And so all the clinicians have to do is, click a thumb up and it's ready to go. So obviously huge pro is there's no haul for them whatsoever. I I think, again, having one person, it's led to more consistent communication since that's her sole responsibility. The cadence of communication is just much higher. And so I think with that also, we have really high patient engagement with it. We have very few that opt out of it or get off of the platform. And so that's, at least even just for the set it and forget it codes where you just need to be set up and not, opt out of it. We do really well on those because we enroll everybody, they're advised of it, and we have really good engagement with it. And then just the platform that we chose is just super user friendly on both sides of it. Patients don't have to log in. It's purely a text, communication. So it's just an easier system, I think, to utilize. And then the billing, again, just I guess with the consistent communication, the billing is also consistent with that too. So to Craig's point, and just the learning curve of 30 days and calendar and when do you do it, and if the patient's already been discharged, but then you're not notified for the available code until after that. So she's kind of got everything dialed in a system to make sure we're capturing the billing when it is ready to go. I would say the con with that is, similar, I guess, to clinician engagement with it as well, and how much your clinicians are utilizing it. She is sort of out of sight. And so I think there are some times where I wish there was a little bit more face-to-face engagement with it, or even just, before the session. So they're getting that face-to-face contact point in there for billing is less for some than it is for others. And I think it's just because that is fully automated and outside of us, the clinicians in-house are not as engaged as I would like them to be. And so we started implementing a system where she messages and she puts an email out every week and like, hey, here's who had the most, patients that were engaged in communication over the week. It's sort of like celebrating the top performers in RTM for the week, and just to encourage a little bit more staff engagement, and that she's touching base with the clinicians that, hey, I'm here, I'm a real girl, and just don't forget about me. So that's maybe a little bit of a con to having it legitimately or literally offsite and remote for us. And then, like I said, just the financial piece of that in the beginning, it was a big learning curve to recognize who do you enroll, who do you not bother with, and then just professionally, are you doing a disservice for those that would probably benefit from it, but have an insurance company that doesn't cover it, and kind of, I guess, just ethically getting around that piece of that. So those are probably the bigger ones for us.
I want to come back to so I love that you touched on how the communication works and that she's sending that weekly email. She's putting the information in the chart so it's right in front of the provider. How do the therapists feel about having a second person inside their charts and potentially, reading their notes and getting up to speed and communicating with their patient?
They actually like it. I think it helps them prepare for the next session as well. So if, sometimes we'll open the note, and if the patient hasn't been here in 2 weeks or something like that, there might be, 6 messages from, they were really engaged with RTM during the time that, in between the sessions. And so it gives the clinicians a heads up. And so they can better prepare for the session. If they see that something, transpired, they see that there's difficulty with a home exercise program, whatever the case may be, it helps them prep for that treatment session a little bit easier because now they're going in informed. I think we've all been there where you've got a game plan and the patient comes in and you're like, delete, 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 because they're, coming in completely, different than you had sort of anticipated. So that has worked well, or that's been sort of the pro, that they're seeing those things and prepping them, they're being prepped for the day.
Perfect. When it comes to not enrolling certain patients that have a specific insurance that it's not going to be covered, have you noticed any differences in their outcomes, or any differences? So that was something that I was concerned about, since we're out of network, and we kind of created a specific contract so that we can enroll our cash pay patients and not have to, worry about having it be asymmetrical. What are you seeing with that?
A good data collection thing. To be honest, I have not looked at really the data on that, only because I don't know that I would be able to attribute, drop off or arrival rate or outcomes solely to that, just because obviously so many different factors. We call it like a multi-niche clinic. I mean, I have pediatric specialists and I have geriatric specialists in pelvic health, and our demographic is literally 0 to 100 years old. And so I don't know that I would be able to, the nerd in me would say, like, too many variables that I'd be able to scientifically say that was solely due to their RTM, thing. But it is worth
Fair.
probably looking.
All right, Haley, pros and cons of the white glove model.
Yeah. So the first pro is just that it's very therapist first. It really helps our staff. Our staff are already, trying to keep up with all of the different requirements for charting and coding every single day while they're still seeing a patient. We're on 40-minute blocks, and it's pretty busy, and we have smart wait lists, so we have very little downtime in our day. So having the white glove approach really, really helps our therapists. It's been awesome from their perspective to be able to start using RTM, but not have to learn all of the intricacies of the coding and the tracking for it. Another thing that ended up being a big pro this time around for us is that we're partnered with a company that's really been partnered with us. So we have been able to get a lot of support from the company that we're working with. When we were switching over to the HEP platform, sometimes we had big lags in response from our EMR in emails of asking questions, but this other person that we're contracted with was so quick to respond to all of our questions. They led one, if not kind of like a full in-service for all of our clinicians for us that just kind of went through all of the different things to expect and to do as we switched over to RTM. So we ended up getting just a ton of support from the company that we're using that we almost didn't anticipate. So that was great. I would think of the white glove approach for us. It's really felt like an accelerator. It's really felt like where we are right now is probably where we'd be a full year in if we didn't have these guys. So they've really helped us kind of keep our foot on the gas and keep it going and getting these codes through. One thing that I want to touch on a little bit about the relationships, because yes, it's a pro and a con of using these remote care navigators or having someone who's not in the clinic physically helping to manage these cases. In our situation, one thing that we did was we have photos of our actual RCNs up in the clinic. And all of our patients are saving their phone number and they're introduced. So like at my office, it's Brooke. So we're like, okay, I want you to do your homework. I want you checking it off. You can message in the portal. Brooke will probably reach out once a month. Just to kind of help me make sure that everything's going really well on your end. That being said, our clinicians also can do the live interaction themselves. So we don't have 100% RCNs doing it in the background. We do have our own clinicians managing that. And then for the way that our EMR is set up, all of the messages that are coming into our portal, in the HEP portal, they actually go to the clinician, and the clinicians are managing most of that themselves because we really like to message our patients back, right? Like someone went on vacation and they fell, and I got that message and I responded right away. It wasn't Brooke. And so she's there as like the safety net for us. So our clinicians are still doing a lot of that communication in between sessions, but our RCNs really help as like the safety net for those patients that are falling off, those patients that aren't doing their homework, those patients that do need kind of a constant check-in or a little more than what our clinicians have to offer time-wise. So we definitely worked hard to bring our RCNs in as a part of the team. So when we introduce them, they're a part of our team. We don't talk about them as being separate from us. I'm partnered with Brooke. She's going to give you a call. Here's her face on a piece of paper. We actually give them a handout as well at the eval that has more information about RTM and Brooke and everything else. So our patients are walking out of here. They really know what to expect on day one as far as what's coming down the line. But that sharing of the relationship is a bit of a con sometimes. And that's definitely per provider. We have some therapists that are like, I just want, the RCN to do everything for me. Like, I don't have time for this. And then we have other therapists that absolutely want to be the only communicator with certain patients. And we just make all of that clear in our documentation. And we haven't really had any big issues there. It seems like the more that we introduce it as a team approach, it's been going great. And then over the last couple of months, I think some of the RCNs are getting to know the therapists better that they're paired with, and they kind of know, if we want them calling more or less and that kind of thing. So because we just have because we have 8 offices and 4 full-time RCNs plus a part-time OT, so we've got PTAs and then we have a CODA as well helping manage the cases. They're mostly doing back-end stuff. So they're getting the codes together. They're creating, super compliant documentation for us. They're kind of teeing it all up, and then the therapist gets to push it across the line. So they're really helping with the stuff that our therapists don't want to do. But our therapists are still kind of that front line as far as patient communication is concerned. So that's where we are. And then the other cons would be, obviously it takes a piece of your margin. So you are sharing those, you're sharing what you're bringing in from those codes. And in the beginning, as we do figure out the insurance ins and outs and who we're auto enrolling and who we're letting choose if they want to be in it or out of it, every time you write off a code, because of how our contract is set up with our company, you're paying them to process that code, but you might not have received any money for that. So we're kind of figuring out kind of how that all looks on our end. But that would be, the con is just sharing that allowed amount that's coming into our bank account with the company that's kind of teeing it up for us. Right now, it feels really fair because I don't think that we would be able to generate the codes that we're generating without their help, because our team is just so maxed out with patient care. So
While we're talking about the revenue part of things, Carol asked, what is the potential additional revenue that a therapist could bring in? Whoever wants to jump in and share ranges for her. For everyone, I know that's something that you want to know.
Yeah, I'm curious how similar our three numbers are, but we found our therapists who are really good at it generate about an additional $1,000 a month in revenue.
That's probably pretty close for us. So we're bringing in about $7,500 a month in revenue. So we have how many do we have? I have 14 PTs and then 5 PTAs. So depending on, I guess, who you would assign that patient to. So if the patient was truly for the PT, then we have 14 PTs and bringing about 7,500.
I have not broken ours out by clinician, but in the month of March, we had a 60,000 allowed, and we brought in over 50. Our denial rate for RTM right now has been between 2% and 3% every month. And we're keeping about 46% because of how we're sharing that right now. And we anticipate that being closer to 50 or a little bit above 50 as we get more efficient with fewer write-offs, and just kind of figuring out our population a little bit better. So we've definitely seen a positive this time around. In our first full month of doing RTM, we did better than what took us 6 months to do last year on the other platform. So we definitely did things better the second time around. We learned a lot.
To give you the financial difference of what Haley said of just because she saw the problem they got going right away, right? And I felt like it took us years to really get going. So we had probably 2 years of one therapist or two therapists doing it really well and a few people kind of dipping their toes in. And it would be as a company with 40 therapists, we would be an extra 3 or 4 thousand dollars a month in revenue, where I think Haley just said they got really the allowable amount that collected 50, right? And sharing some of that, but now we have a company where most of our therapists are doing it pretty well. Not all, but most are doing it pretty well. And we're 20 to 25 in terms of collections a month, but it took us 2 to 3 years of trying to do it to get to that point.
Thank you for that add-on, because we brought in 4,500 for the entire year for all of our therapists the first year that we implemented it. So definitely learning curve, and hearing $1,000 a month feels like, okay, this could potentially be worth figuring this out. Carol, any follow-up questions?
There's a question in the chat about how many codes were billed out in March. It was 1,613. So codes were billed out. And there was a question a little further up in the chat about what to expect if you were to go with one of the white glove companies or someone who's going to help manage the codes on the back end. And that does look different from company to company, but I can tell you the one that we're using it's a split of the codes. So And it's not a percentage, it has to be a flat rate. So they look at the national averages of reimbursement and then they choose a rate that looks fair to them and to us, and that's what we've agreed on. It can't be a percentage. There's something weird about it being a percentage of what's brought in, I guess, legally. So for us, we pay a flat rate per code that they generate to them, and they process that as an invoice every month for us.
I do have an additional question. The therapists that are successful in bringing in an additional 1,000, how much time would they typically spend, and is it usually on their own time?
Yeah, so for us, we have a little bit of a unique model where our expectation is our therapists are going to complete like 30 hours of patient care a week. So we give them like, hey, you have 10 hours a week to any meetings you need, any communication with patients you need, anything like that. That was kind of our standard, and this is added in, right? We didn't really give people any specific time to do this because we felt like we were already pretty generous uh, in doing that. And also our therapists, a lot of them were doing this anyway, otherwise. So we basically been able to say, like, listen, this raises the salary ceiling for you and allows us to do that. But we're not giving you more time to do something you were already doing without getting paid for.
Right.
Yeah. But I also I think there's a ton of like if most therapists are more scheduled out than we are, they're like more appointments. We're kind of all one-on-one with that. And like again, only 30 hours is pretty low. We're at a pretty low it's not the most expensive place to live here in Indiana, Kentucky, Illinois, rural Illinois. So there are things that we can do a little bit differently there. But I also think if somebody's able to, if you can consistently generate $1,000 in revenue to say like, yeah, here's take a slot or maybe even two a week to do this.
Thank you.
Kristen was asking about what platform each of you are using. So I know Prompt was thrown out.
Yeah, we're on Prompt Engage.
We're using Sarah Health, and I get no royalty from them, but similar to Haley, I mean, they've just been phenomenal to work with. And I think that's also been part of our success is just the communication. And when we first started, just trying to dial in the process and who's paying and who's not. And they were sharing just nationally what kind of reimbursement was doing to help us make some informed decisions on who to enroll and not. And it too is just a flat fee for the codes. And I agree, it's pretty fair.
So we use Prompt as our EMR, and there is the Engage that is tied to that and would make it easier. We have always used MedBridge as our home exercise program platform, and we gave our therapists the choice, like overall, of just like, do you want to learn a new HEP software, or do you want to kind of have to apply this that's not connected? It's going to be a little clunkier, and everybody chose like we want to continue. We like MedBridge, we want to continue to use it. We want to use it for RTM. So arguably, we're using like the harder RTM connection point that's not directly involved with Prompt there, but our clinicians do like MedBridge.
You're
I
highlighting
would
some
throw out on
inefficiencies.
that. We did a lot of homework on that. And I will say, just for those that are not utilizing it and demoing it, my advice would be really consider who your patient is and just the user friendliness of that. That if they have to log in, create a password, create a username, there's going to be less likelihood for that. And again, I don't know if I'm even really supposed to promote anybody, but the organization that we utilized made a really good selling point that they are an RTM company. That's what they're designed to be. They're not a CEU company. They're not a, HEP company, that they are specifically designed for RTM. And so the ease with which it is, just the ease was a big difference compared to some of the other ones that we had demoed. So I would just encourage you, like, demo several of them and kind of decide what would be the easiest for your team to utilize and your patients.
I guess, and just for those that haven't like looked into having the white glove approach, that's not provided by Prompt Engage. That's a separate contract that we have with someone else.
Jill, I'm going to call you out again since Nisha has a wide range of patient populations, and I know you're in pediatrics. So do you have any specific questions of how it's working with that population?
We haven't implemented anything yet. I did some interviews with some companies just to find out how it works. Um, I think ideally I would love a dedicated person to be able to oversee this, much like Haley describes, like an RCN type of person. I'm kind of wondering, does that person have any special qualifications? Are they, I know you could build times too that your reception is speaking with the patient and doing all these things. So who do you hire a clinician to solely overlook this if it's not the specific clinician billing or doing this, or is this part of that white glove service contract that you have? I know a colleague of mine does a lot with overseas contracts now, which is more affordable for him to have things managed. So I just have so many questions because as a smaller two clinic owner, I think the lift and the cost is there's less room for error, honestly. And I don't want to hire and get all this started and then I end up with nothing because I don't take Medicare. So I don't have Medicare patients. So if all these companies are going to just deny the codes and I hired somebody, I'm just nervous. I don't know. I know that was a ramble. I'm sorry.
No, since Nisha has pediatric patients, I thought maybe she could share a little bit about how it's working in that population.
Yeah, certainly less, but also less enrollment in that population. And I keep going back to kind of our community, but a good portion of our pediatric patients are TRICARE outside of the base, and so they don't cover RTM, and so a lot of our pediatric patients just aren't being enrolled in it. I would also say the clinician that is doing it, her area of expertise is in neurology, orthopedics, and sort of the older adult population. So I think certainly easier for her to engage with those patients just because they're, speaking the same language. I think that would be a heavier lift for her to kind of, provide great quality clinical advice for our pediatric patients and things like that. But we have less engagement with it, but we also have a considerably less enrollment with that patient population.
Thank you. Along the same lines, Craig, Lindsay wants to know how the Medicare population is getting comfortable downloading MedBridge and logging in and getting used to that platform.
Uh, Yeah, so I truly believe in what Nisha said here is there are platforms that are easier. We're using still like a little bit like MedBridge has newer things now where they have built something that they found like nobody wants to download an extra app. Like Nisha said, like if you can just make it something where they can basically text with that all that stuff matters a lot. So for us, we probably have to spend a little extra time. Like we get that downloaded with them in the office. Our front office team knows how to do that with patients. Our therapists know how to do that with patients. And we also like probably the easiest transition we've made is that like this is just what we do. We don't really talk about it as an option with patients of just like, hey, we use this. You'll download this app that'll give you access to us between your sessions. It'll give us the ability to change. And very few people like bat an eye at it when it's not like uh, an option of you don't give them a menu of things to choose from. This is just how we do. That's one of the things. Even like we know there's some payers who don't pay for it. This is just what we do, and that is something that we do it with our cash pay patients. We do it with our out of network. We do it we're in Illinois, so Blue Cross Blue Shield. We do it with them, even though they're not paying us. But they do pay us way better in Illinois than they do in Kentucky and Indiana otherwise. So we're able to kind of like justify it in that way. But yeah, there are much easier platforms than what we're using. And as a result, we walk patients through that.
Perfect.
We've had both. So our first company that we went with was a text, and it was a browser-based system that arguably is simpler for the older adult. But then now we're on an app again, and initially things are just changing all the time. So whatever you go with, like go with maybe see how often they're updating and changing things. Because like Craig said, MedBridge will probably have both options. and so will probably Prompt Engage. But when we launched the app in January and February, there were different authentications and other things that had to be involved for them to log in every time, and it was a complete nightmare. Well, they turned around really quick, reprogrammed it, and made it a lot easier. It's still not text-based or browser-based, but they did simplify the platform right away. So there's constant change in the tech behind all this stuff. I think.
Okay. So that pop-up survey means we're in the last few minutes. Any last minute questions? Callahan, do you have anything? Nothing right now.
I
Dave, go
have
ahead.
one.
Of course.
But for Craig, I love the way you approach it, Craig. That this is just what we do. We've talked about that. With those where they have zero coverage and they end up with a substantial add-on cost, how much backlash does your billing department get, or how do you handle that? Has it been a problem at all?
So we're not getting paid by for the patients who their insurance does not cover these codes. We raised our out of network cash rate and our just plain cash rate. We raised those rates to say like we're not going to we're going to do remote RTM with this patient who's out of network or cash pay. So we're going to charge them more. We went back and forth on that, but it is just we raised those rates and it is just included now in the price to see us. So there's a few small payers where we just don't get paid and we don't chase the patient for it. We don't have them fill anything else out. Like we don't do that. And maybe that's something we'll get to eventually. But overall on the patients who like we do tell them like, hey, we give them a cost estimate form for every visit of like, hey, here's what you can expect to pay us every time you come in. So it's covered there. And our billing team says we get very, very few complaints on this. No more so than we do, the rare complaints we get on anything else. So as long as we're doing a good job of telling people like, hey, here's what you can financially expect to pay when you come in, we find it's been good.
I may have missed something. What you said, you raised the rates on what to kind of.
Oh, yeah, so we're out of network with a few major payers
Oh,
and
okay.
like we don't even submit out of network to healthcare. Uh
Gotcha.
that that we basically so it's a cash rate, right? So we raised our cash rate for all of
Got it.
those when we
Okay.
started just saying, hey, this is just what we do. And we're not gonna go back and forth of like we're doing it with this patient, but we're not doing it with this patient. So there's an add-on. It's just what we do for everybody.
Okay. Thank you.
All right. Well, thank you to our panelists, Craig, Nisha, and Haley, for sharing the behind the scenes of what this actually looks like, because from the outside, it could be really intimidating to get started. And I appreciate the transparency of what's actually happening. And I put everyone's contact information in the chat. So if you have any follow-up questions for anyone specifically, you can reach out by email. And then I am going to give us the next two sessions. So our registration links for June, which is our payment panel. So that is always the most popular one of the year. And July is business development. So these sessions are always the fourth Thursday at 1 o'clock Eastern. So I love seeing familiar faces like Andrew showing up every month. And hopefully we continue to optimize this to whatever you need to grow your practice. If anyone has 2 minutes to hang out and give me some feedback, I'd appreciate if you stay on. Otherwise, I hope to see you next month.
Thanks, everyone.
Stephanie.
Thanks, Haley. All right. If you're staying on, I'm going to ask for your just quick feedback of what you thought of the session and if there's anything that we could do better in the future. So Carol, you're up first.
I'm eager to talk. This was really helpful for me because I'm probably 65% Medicare and in Manhattan, and it's really hard to keep up with the salary expectations of therapists when reimbursement in New York State is so low. And so up until now, it's just been something I've been overwhelmed by. But now I'm actually excited to look into it and figure out a way to do it. We use MedBridge now, so that was encouraging to me that that might be, a good place to start demoing. So thank you for doing this.
You're welcome. Thank you for coming. Callahan?
Yeah, I was just going to share. So, Stephanie, I sit on the digital health subcommittee of the payment policy committee for private practice. And so I more just wanted to offer if there's additional resources that we can provide on the digital health subcommittee. We've done quite a bit in the RTM space. And so I'm happy to give those resources to you as far as a follow-up to kind of point people towards some of the other webinars we've done, resources that we've created around RTM to hopefully serve the membership in a way as kind of a follow-up from this.
Absolutely, that would be so helpful. We normally send resources with our replay. So if you could send that over to Sarah, that would be super helpful.
Yeah, I can definitely do that.
Thank you.
Callahan, I'll put my email in the chat, and if you want to email that over to me, we can include your resources.
Okay, that'd be great. Thanks, Sarah.
Thank you.
Thank you. Jill, how'd you feel?
I feel like every time I sit in on something about this, I'm learning more, which is so helpful. It's a transition time for my practice, so I'm hoping to implement this at a different time, but I'm always more comfortable doing this when I have more knowledge. So again, I think it has to be a separate person kind of spearheading it, is how I see it being implemented. But it's been really interesting to hear all these little tips and techniques of people that have felt the aches of the mistakes too. So I'm grateful for the input.
Yeah, I think that's what I love most about these monthly sessions is hearing some of the behind the scenes and understanding, okay, we're not the only one that misstepped here. And okay, they got past that, so I can get past it too.
Right, right. And someone had said too, it really becomes if they, as a smaller clinic again, to meet the expectation of salaries and raises, it has to come from somewhere. So if this is in a nice way for our patients to even have better care, it's a no-brainer, and like you said, we do it anyway. We're pediatrics. Our parents are always wanting to reach out and ask questions. And we do it through phone, they call, and we're white glove ourselves, we all are. So I really try to might as well get paid for it, right?
Well, thanks for coming today.
Thank
If
you.
you have anything to add, what'd you think of the session?
Guess you said me. I didn't quite hear that, but I thought it was great. I love the transparency of the panel. I'm partial to Haley. She's my partner, but no, I really enjoyed hearing from the others. I liked hearing Mr. Pfeiffer's. Is it Craig? I liked hearing how he's gone full on with it. I like that we've talked a lot about this is just what we do. This is part of our service. Some of those comments were helpful and shows us that, it could be something we take over a little bit of the ownership with down the road. But I think the white glove approach where we give less to our therapists and we are able to do more RTM by doing that, it is a benefit for us. It was good to hear all the perspectives. I thought you did a good job hosting and it was a good session. So thank you.
Thanks. And thanks for volunteering Haley to come on as a panelist. I really appreciate that.
Yeah. All
Well,
right.
enjoy the rest of your time in Florida, Dave, and
Thank you.
thank you, everyone else. Really appreciate it.
Bye-bye.
Bye. Okay, Sarah, I'll hang out with you for a minute. And Olivia probably walked away. Oh, you're just on mute.
Well, everything went really well.
Yeah, that was pretty smooth, right?
Yeah. Yeah.
Think it was good. I knew once we started talking about finances, then we were going to have pinging questions all over. I tried to save that towards the end. But
Yeah. Yeah. I'm sure our payment session, like you said, is like our most popular session. And that's next
yeah,
month.
yes. So I will get you some promotional material soon. Do you have enough to send the first email out, or do you need a description?
If you could do a description, that would be great.
Okay.
And then Callahan she said she would send me some resources. Yeah, so if we could get a description, I could send something out tomorrow.
Well, I'm sorry, I was asking about for the June promotion. Are you doing the replay and the promotion for next session in one email now?
Yes.
Oh,
So we
okay.
do like thank you for attending. Here's the resources. Stay tuned for the next one. And it's like a short description.
Okay, perfect. I didn't realize that. That's great because then they're getting the sign up link right away.
Yeah, yeah. If that cadence works for you, of course.
Yeah. It should be almost the same as last year's description, so I'll just peek at that and see if I need to make any minor adjustments. And then I will work on seeing if I could get our panelists to do a video.
Great. Sounds
Okay.
good.
Thank you. Appreciate your
Thank
time.
you. See ya.